introducing Dr. Rachel Huckfeldt. She is an assistant professor of ophthalmology at Massachusetts Eye and Ear and Harvard Medical School. Her clinical practice and clinical research are focused on inherited retinal disorders, and she led Mass Eye Ear's involvement in choroideremia gene therapy trials sponsored by Spark and Biogen. She is also the co-chair of the Foundation Fighting Blindness Clinical Consortium, as well as the academic chair of the CRF Scientific Advisory Board. Dr. Huckman?
Thank you so much. I'm really happy to be here at this meeting, and I have to tell you, I felt like kind of silly about telling people who are here at this conference for a reason what to expect when they go to the ophthalmologist. And I'm happy to see some of you in the room here to humor me. But I hope that I can make this a succinct, especially because we're running over presentation, but one where maybe you learn something about why we do what we do and the context for it. I do have some disclosures that won't be so relevant. They are not relevant to what I talk about today. And I have three big chunks of what I want to talk about. One is choroideremia in the medical context of ophthalmology and optometry care. This is not what to expect, but this is maybe why some of you may have had the experiences that you've had over time. I'm going to talk about what we do at the ophthalmologist and why, and then touch on other resources that we try to make sure people are tapped into. And I'll start with context. And this is not meant to be an apology for any bad encounters anyone has had in the past. But optometry and ophthalmology training, it's pretty brief. For those of us who are ophthalmologists, we spend 3 years learning everything there is to about medical problems of the eye and an essential core group of surgeries. That ends up being a very short 3 years. And I mean, I work at Mass Eye and Ear, which is a Harvard teaching hospital where we are so proud of our inherited retinal diseases clinic. We have between 8 and 10 residents a year, which means up to 30 ophthalmology residents on site at any one time. How many of them come to my clinic? Not many. And it's not ill will. It's not that people don't think it's important. It's just all the competing demands for their time. Same is true even when ophthalmologists go into the final level of specialization as retina specialists, for example. And against that really limited clinical experience and training is the complexity of inherited retinal disorders. So on the screen, I have 3 retina pictures from 3 fairly well recognized inherited retinal disorders: Stargardt disease, RP, and of course, choroideremia. They look really different from each other. How they look in a textbook, because maybe somebody saw 1 or 2 textbook pictures in training, maybe if they were really lucky, they met a few patients. Well, how patients come into the room may not exactly look like these pictures. And then focusing on choroideremia, we know how it looks changes a lot over time. So now I still have 3 retina pictures, but starting with a 10-year-old with choroideremia, then an adolescent, and then a person probably in their 50s or 60s. And I think every eye care provider would recognize the last picture as choroideremia. Probably most of them would recognize the middle one, or at least be pretty close. But the first one, a child with choroideremia, doesn't look like the textbook, right? And so the kind of exposure that trainees have to these in training is not how they are going to encounter them in the real world. And so this kind of limited clinical experience, it really snowballs in some interrelated ways. There are some parts of the country where there may not be people who have focused expertise in things like choroideremia. People may walk into the eye doctor and we heard in the last session from carriers be told some pretty wild things about going blind tomorrow. I can speak from my own patient population about just the lack of knowledge that causes well-meaning doctors to say things that aren't quite accurate. And so these are challenges, right? These are challenges that the healthcare system needs to meet to better take care of people. but there are plenty of solutions underway. Something that I'm really happy to lead is our actual dedicated one-year clinical fellowship at Mass Eye and Ear for ophthalmologists who want to specialize in inherited retinal diseases. So that is a very focused year where, hopefully people see, I don't know, between 20 and 50 people with choroideremia in that year. I have on the very bottom the title slide from a presentation to the American Academy of Optometry that Corey McDonald organized a few years ago. And the title was Choroideremia, Differential Diagnosis and Why It's Important Today. And this was like a half-hour presentation to a few hundred optometrists about how to tell the difference between choroideremia and X-linked RP. That's pretty awesome, right? It's pretty awesome Corey put that together because we are capturing a big audience with that. And then, just speaking to access in general, it's things like the Foundation Fighting Blindness sponsored genetic testing program, where even if you're seeing somebody who's not too familiar with genetic testing or how to order it, here's an avenue to get that done. And then, frankly, anyone here with choroideremia is part of the solution too, and that is a burden sometimes, I'm sure, but it means that your doctor is hopefully getting a little smarter when they see you and other people. So that is kind of the backdrop against which some of these very cringeworthy and appalling clinical encounters sometimes happen. But I want to turn now to what I do, how I approach the clinical care of somebody who might have choroideremia or someone who I know has choroideremia. On the right hand of the screen is a picture of the hospital where I work. It is a pretty brutalist style concrete building from the 1970s, but nestled underneath it is the old, more than 100-year-old building where my clinic is kind of nestled in on the third floor. And when people come to our clinic, and I think at least one person in the room can talk about this from experience, we have a pretty set list of goals that we have in mind that we're going to tailor to that patient on that day. And I'll get into details in a moment, but it's, understanding a person's history. It's making sure we understand their visual function and their retinal function, making sure we understand the changes in the retina that underlie that vision. And then when relevant, having somebody meet with our embedded in-clinic genetic counselor. And I think clinicians who specialize in inherited retinal disorders are probably the biggest question askers of all ophthalmologists. I've asked people about any body system they have. I'm sure I've asked a question about it. And we sometimes feel a little bit like detectives, especially if somebody is coming in without a diagnosis. But I want to understand how old was somebody when they started having difficulty with night vision or peripheral field or whatever the symptom is. How have those symptoms evolved over time? What have they been told about their diagnosis over time? Has already been kind of touched on earlier this afternoon. There's a fair amount of RP out there that's actually choroideremia, right? And so as I'm sitting and meeting someone, what am I going to end up thinking this is at the end of the day versus the diagnosis the person's coming in with? We want to understand their medical history because for genetic retinal diseases in general, not for choroideremia, but for some of them, they can travel with problems in other parts of the body. For obvious reasons, we ask a lot about family history. And then I care about social history. What does someone like to do? What is their job? How does anything they're experiencing with their vision get in their way of doing that? And that is priming me to think about resources that I may not have, but that I can perhaps hook them up with. Turning to how we assess visual function and retinal function, the first stage is the kind of obvious one. How does somebody read the eye chart? And Tomas Alamet in his talk this morning said something really important, that is just because somebody has 20/20 vision doesn't mean they have normal vision, right? But this is a standardized way that we can use to get one measure of people's vision. So vision on the eye chart, it's really a measure of the acuity and the sharpness of central straight ahead vision. Even though we write it as a number, so example 20/20, we are lazy when we speak it. We say 20/20, 20/40, 20/200, etc. That top number is the distance from the eye chart. That bottom number is the smallest line that a person could read correctly. And so if my visual acuity on the eye chart were 20/40, it would mean I would need to be at 20 feet to read what somebody with unimpaired vision could read at 40 feet, excuse me. So the bigger the bottom number, the larger you need the letter to be. And again, this is one of many measures of visual function. We also care a lot about visual fields, and in particular, what they tell us about peripheral vision. So on my screen, I have just photographs of 3 of the more common devices that we use to measure visual fields. The one in the middle is what we rely heavily on in my clinic, and for those of you who have had a visual field, this is one where there's actually a person on the other side moving the light around for you to click when you see it. The pictures flanking it are commercial devices that are automated. They all have strengths and weaknesses. But when we think about visual fields, it's giving us more insight into how a person may navigate in the world and what challenges they may face. So I have in a row going across the screen 4 visual fields. The one on the far left is a visual field of somebody without any kind of impairment or vision problem. And it's really 3 concentric rings. They're not normal rings or circles, but 3 concentric shapes. And those shapes enclose where people can see lights that vary from very small and very dim to very big and very bright. The smaller and dimmer the light, the smaller the circle in which the area in which the people can see it. We know in choroideremia in particular that, and for those of you with choroideremia, you don't need me to tell you this, that these fields will change over time, often a very stereotyped pattern. And so by following people over time, we get a sense of where they're at any one moment, and then how that changes over time. Does somebody's visual field, when I'm seeing them today, do changes in that compared to 5 years ago, for example, kind of correspond to what people are thinking about or encountering in their day-to-day life and telling me about? And so these 3 images on the right are from a paper describing progression in choroideremia. And I think, sometimes visual fields are just kind of affirming to people that what they're experiencing, has a basis in what we can measure. I think sometimes they're really helpful for family members too, to understand what it is that their loved one is kind of using and seeing on a day-to-day basis. Jasleen Jolly in her talk, talked about a few tests that were the ones that nobody liked, and I think I have her beat with this one, which is electroretinography. We abbreviate that as ERG. For those of you who have not had it, or for those of you who have had it and tried to forget about it, this is a test where we first put you, Mary's like, it's resonating with Mary. This is a test where we first make your eyes as sensitive as possible to dim light by putting patches over them or putting you in a pitch black room for up to 30 or 40 minutes. And then we have different ways of measuring it, but often within a special contact lens that sits on your eye. And we flash lights at you. And this isn't arbitrary or random, of course, but it's really letting us measure the fundamental starting point of vision. So I have a pretty complicated diagram on the left. The details of it don't matter that much, but it's showing the different layers of the retina and the different cell types that ultimately are the start of the electricity. That is the starting point of vision. And so depending on the kind of light we flash at you during the ERG, depending on its color, its intensity, we know that we are exciting different combinations of the rod cells that we use for nighttime vision, the cone cells that we use for daytime vision, and all the circuits that relay their messages through the retina and ultimately to the brain. So I think historically, this was a test that certainly at Mass Eye and Ear was done every single visit. As some of our other diagnostic tools have evolved and become more sophisticated, we are using it, I am using it very intentionally and judiciously. If I'm meeting somebody for the first time, I'm actually really interested in how much rod function do they have? They're telling me they do have difficulty at night, they don't. What are the rod measurements that go with that, for example? So it is still a test that has a role, but not a test that is as important every single visit as some of our other ones. And I'm going to just take a step back for a second. When we're measuring visual fields, anyone of you who has had a visual field knows you're putting your face in a dome, and it's very bright in that dome, and you're being asked to see little flashes of light within it. That is actually an environment where that light is bright enough that any rod cells that somebody has are actually suppressed and turned off. So when we're measuring visual fields, we're really looking at how well cones work, at least the standard clinical way we do it. We're looking at how well cones work. So that means in some visits, unless we do an ERG, we're not getting a rod-specific measurement. And these are, again, if you have a little bit of memories you'd like to forget, cover your eyes. But we have different ways of putting electrodes on the eye. I joke, but the goal is it's not uncomfortable. In the top left, you see one of my technicians with a special contact lens on her eye, some ground wires on her forehead and behind her ear. There's a picture below that where you see a woman where what you'll notice is like 2 white dots on either side of her eye. There's actually a thin filament that runs between those dots that's positioned underneath her eyelid. That is another way of recording an ERG. And of course, the stimulus dome where you have to put your head when the ERG is being performed. But I think what has become really more powerful, and this is advancing without me, what's become more powerful over the last 10 to 20 years is really our ability to look at the retina. And so just as a reminder, on this cross-section of an eyeball, the retina is the thin film that lines the back of it. Let's see if this pointer works. It's coming more than past the midline there. And when we are looking in clinic, we are holding up lenses to your eye. If you're keeps advancing on me, put that down. If you're sitting and someone's holding a lens up to your eye, that means we're looking at the very center of the retina, the macula. If you think about the retina as a bowl up on its side, the macula is kind of the base of its bowl. So by holding that lens up to your eye, we're able to see it in just exquisite detail and with more 3D dimensionality than any picture could ever give us. If you've ever wondered, why your eye doctor might put on a crazy head-mounted flashlight, which is shown in the bottom right picture there, that is an apparatus that, with people's cooperation, look up, look left, look down, it lets us really see the walls of the retina, the walls of the bowl. So complementary techniques to make sure we're seeing everything. But fortunately, we have other ways to document things. So we can take beautiful color pictures. In not that distant past, the lights to take color pictures were insanely bright. It might only capture a small little patchwork of the retina. We now have wide field photography. And this image here is not even that wide field, where it allows us to catch a large swath of the retina without as much bothersome light exposure to the people who are having their picture taken. And so these are just ways of documenting what we're seeing, and also kind of a nice check to make sure we're not missing anything on clinical exam. We have other important ways of looking at the retina, though, and anyone who was at the carrier talk or heard Dr. McLaren's talk this morning heard a lot about autofluorescence. So in the images I have here, there is a column of color fundus pictures. To its left, there is a column of autofluorescence pictures. At the very top of the column is normal, and then 3 different individuals with choroideremia. And I hope what you can appreciate, and I'm going to use the pointer to try to highlight it, is that often in the areas that are better pigmented on fundus exam, part of that will light up on autofluorescence, confirming that that is an area that still has intact retinal pigment epithelium and hopefully photoreceptors over it. This is a nice way to track progression over time. You heard this morning from Professor McLaren about how it may be a biomarker after treatment as well. And this image is an example of wide field fundus autofluorescence, where rather than being limited on the center of the macula, now we can get a much greater expanse without the screamingly bright blue light that the other images that I showed you require. And again, just another nice way to track change over time. And then finally, I think a tool that has really transformed ophthalmology and retina care is something called optical coherence tomography, or OCT. And it lets us take a cross-section of the retina with the eyeball still in somebody's eye, right? So on the left hand of the screen is a histology slide. So this is a section from a retinal sample post-mortem where we can see all the different layers that together comprise the retina. On the right is the in vivo image acquired at a clinic visit of somebody with outer retinal problem, where we see all those layers now in the course of a few second image. I just want to highlight a few things here in case you've seen these on the screen in your doctor's office. First, the black at the top of that band of layers is the jelly inside the eye, the vitreous. The smeary white-gray at the bottom of that stack is actually a very rich bed of blood vessels, and then underneath that is the wall of the eye. And then it's the stack of layers that are gray and white that are the retina itself. And this dip here is supposed to be here. This is the fovea that lets us have very fine central vision. And when we're thinking about anything that impacts rods and cones and light-sensitive cells, we're thinking about this black bands. That is actually where the rods and cones reside. And we're thinking about some of these white lines underneath it that I think of as being like their antennas. So when I'm seeing somebody in clinic, those are things I'm looking at carefully. You heard about some of those from Dr. Alaman this morning as well. And then we put it all together. So we look at how does what we are seeing on our exam with our lenses compare to what the OCT and the fundus autofluorescence are showing us, and how is this changing over time? And then very importantly, I don't have a nice slide to show this, but we think about how is a person's visual function as we measure, how is that corresponding to what we're measuring with pictures? And I've been talking about choroideremia generally. I just want to emphasize that the same kind of imaging is very useful and valuable when we're meeting carriers. So this is imaging from a carrier female, with mindfulness of the prior talk, probably on the milder end of the spectrum. And then finally, Dr. Rizzo made the point so well this morning, at the eye doctor's office, we're thinking about visual function. We're not thinking so much about functional vision. I think about it. I don't have the capacity usually in the ophthalmology office, though, to help to do anything about functional vision other than help people find resources. And what I think geographically there's some difference in whether people refer to vision rehabilitation experts as vision rehab or low vision. They're kind of one and the same. I think this is something that's important for any ophthalmologist or optometrist to make sure that our patients have access to and know who to go to when and as relevant. Certainly in Boston and New England, I kind of know the point people to go to. Hopefully everybody's eye doctors have that same information for their areas. There are some web resources, and I have screenshots on the left and right for those that may be kind of just a helpful directory as well. I will say the resource on the left, I was curious, and so I put in Massachusetts to see who it brought me to as low vision specialists in Massachusetts. Apparently there aren't any. So that is just to say, not all databases have all information. And I can't do a better job than Dr. Rizzo did this morning talking about some of the abilities and things that vision rehab experts focus on. But I guess when I'm trying to convince maybe a reluctant person that it's worth another trip into Boston or another trip into an eye clinic, I portray them as problem solvers. And I say, please think of things that have become challenging for you to do at home and bring that list to the vision rehab expert. and let's see what they can think of to help you. Mental health is also a resource that I want to make sure people have appropriate attention to, again, when relevant. Even with a robust and wonderful network of friends and family, sometimes it's really helpful to have a professional and someone just outside that ring to talk to. Especially after the pandemic, a lot of mental health providers had very long waiting lists. I think something I've heard from patients over time too is, well, I had to spend like 2 hours just telling them what it was like to have a vision problem. That's maybe not time well spent. At Mass Eye and Ear, we are really lucky to have a psychologist that we can directly refer people with inherited retinal diseases to. And so he gets vision loss, right? You can kind of just start from a sprint with him. But it was really wonderful when in May, Foundation Fighting Blindness announced a partnership with a highly regarded mental health resource provider called Alma, to just make it easier for people with any kind of inherited retinal disease find mental health support. And then I think this is my last slide. Finally, it's so powerful to have organizations like CRF or other disease-specific patient and family groups to refer people to. It goes a long way. I quite a few times have been in clinic and pulled up the CRF website to make sure somebody who maybe had this diagnosis for a long time but didn't know about CRF knew about it, or to share it with a newly diagnosed individual and family. So it's really powerful what the community and information that CRF offers people as well. And then, clinical care takes a team. It takes technicians who are patient and kind. They're shown in the middle picture of my slide. It takes genetic counselors who know their stuff. We have 3 at Mass Eye and Ear. On the very far left is one of our counselors, Emily Place, and then it takes clinical colleagues. And so I'm happy to work at a place where I get this kind of support so that I can hopefully take good care of people. And that is all I had. I know that Joy Vincent has a talk. I'm happy to stick around afterwards, though, and answer questions, but I see one right now.
And 1 CHMR.
Yeah.
So for him, it's like every year we do the test, and ERG in particular, which is the hard one. How often should we do this test, and especially for younger patients? So that's my first question. And on top of it, to add to the complicated things, is between seeing a clinical specialist. So for instance, we are seeing Dr. Tseng in New York, and then we're seeing Dr. Alleman in Philadelphia. How important is it to keep an ophthalmologist that is more regular as a follow-up? And do we always need to do the test over and over in every location?
Yeah, that's a really good, important question. I don't want people to hate coming to see me, whether they're adults or children, right? So I'm mindful of, as a scientist, I love data, but I also want to make sure that the data I'm collecting has that I need it, right? That it's going to inform clinical care if it's not part of a research study. And so that's not to say any other IRD specialist or choroideremia specialist is right or wrong in what they do. We all have different styles and approaches. And ERG once a year is a lot, especially for a child. And I never mind it when people come to me, patients and families come to me and say, look, do we really have to do this test today? Can we bump this off another year? Is this going to help you today? That's never a bad question to ask. And our frequent model at Mass Eye and Ear too is to have people see us every 2 years, and in the off year see just a regular ophthalmologist, to make sure that with our focus on the retina, we're not missing something in the front of the eye. And sometimes those folks are better at prescribing glasses and things like that. Some of this is style, not right and wrong.
Hello? I saw the mention about the low.
Test 1, 2.
Okay. Hello? Okay. Anyway, the low vision service.
I think the battery's
Anyway, low vision. We took our son down to get evaluated, and basically, I thought this would be great because he was having some challenges at work, and they would have some suggestions. But basically, they said, come back when your vision is worse, your central vision isn't bad enough. And I just felt like I really thought we were going to get help there, and there wasn't any. What suggestions do you have?
Yeah, I'm sorry you had that experience. I think it's not uncommon. And you know, just like not all regular ophthalmologists are the same, neither are all low vision specialists, right? And so when I have people who have had that experience, I say, well, why don't you get a second opinion, right? And that's not to say that a second opinion will bring any epiphanies, but maybe that second set of eyes will come at it with a different perspective. You know, in Boston, we are fortunate to have a few institutes. There's a place called the Carroll Institute for the Blind. You know, should be visually impaired, right? So they have a lot of different programs such that if I've had a patient with a bad or a not helpful experience with one provider, right, I might say, well, why don't you call the Carroll Center, explain what you need help with, and see what they recommend. So sometimes it's work on your part for sure, right? But it's just kind of exploration of what else might be available.
Yeah, I'll take that offline because I want to talk to you about what I really should expect, what can be
Sure.
done, what
Yep.
are the things that are done at
Yep.
a low vision. Thank you.
Thank you. I had kind of the opposite question of the first question was, I see a retina specialist ophthalmologist every year, but we don't really do any testing. I haven't had a vision field test done in probably 10 years, and my field of vision is still mostly pretty good, and he kind of does just a visual assessment, and my curiosity is, you know, how does a doctor kind of make that assessment? I know it's very personal, but to, hey, maybe we should be doing more tests every year. I mean, from a data perspective, it doesn't really impact me. I know what I'm seeing and what I'm not seeing. So I don't know if maybe there's a question baked in there somewhere.
Yeah, so you're right. I think part of it is what equipment is on site, right? So in a retina specialist office, often there is not a visual field machine. And so that just doesn't become part of, or maybe it's like a floor down or like 5 hallways away. It may not be part of the routine. Pictures and imaging are really important because sometimes they can show things that are not a given part of choroideremia that are actionable and need to be identified. I guess you know, for a follow-up patient, my minimum is sort of a visual field and pictures. And visual field, again, just because it helps me understand somebody in the world, sometimes it gives me and a patient confidence that, you know, they still meet legal requirements for driving, for example,
Sure.
right? So there's data points like that is helpful for, but yeah.
Something to consider for my next visit then. Thank you.
Okay, here we go. Some of the CHMers have told me that when they're doing the optical field study, having it tested, that they don't trust what's happening because as they advance in CHM, they just see flashes of lights anyway. So if you're in that, your head's in that little dome and there's little lights being flashed at you and you have to say, you know, you squeeze a button or something to say, I see this. So they're sort of saying that that test is not so useful in the more advanced stages of CHM. I don't know if you ever thought about it.
So it's not just people with CHM that say that, it's people with RP too. And I think that's maybe where the old school manual field is helpful, where it's actually the technician moving the light because those lights are a lot bigger and brighter than the smaller flickering lights that are part of the automated visual fields. So I think some of it may be device dependent. And then regardless, I think with enough serial tests, we get a sense of what might have been distraction that day versus what is kind of more an underlying foundation.
So Corey McDonald may know what he's talking about. Huh?
Corey always knows what he's talking about.
Questions?
Do you think it's worth traveling to go to a choroideremia specialist versus a inherited retinal disease specialist?
I see them as one and the same. Thank you for that question. I see them as, I may have used different words, but I think of them interchangeably. Yeah. And I, to the person who asked the question about the visual fields, right? There's nothing wrong with like a really good retina specialist or just a retina specialist, right? First part of my talk was more to provide context if anyone has ever felt dismissed or given bad information or whatever. So I think there's a lot of very good ways to have care.
Do we have any more questions?
You showed pictures of the field for choroideremia. How is it different for RP?
That's a great question. Often it's very similar. So I wouldn't make a diagnosis just based on a field, right? If you just showed me a visual field and said, what do you think this person has? I would say, give me more data. I don't want to just look at the visual fields.
Okay.
Just a quick question. So, how important is it to regularly see a retinal specialist, or even to see a specialist that understands choroideremia really well? I mean, I understand as a clinician, it's good because we want those data, but like, for example, I live in Arizona, and it's hard to find a retinal specialist that's even heard of choroideremia. So how important is that?
Yeah. So, I often think in terms of worst case scenarios, right? And how do I prevent worst case scenarios? And there are plenty of people with any inherited retinal disorder, that choroideremia or otherwise, that may just go to their local optometrist or ophthalmologist, and that's fine. Again, I like data. In part, not just for the sake of data, but to make sure people are doing okay. And certainly, every now and then, for example, people with choroideremia will get abnormal blood vessels that grow under their retina, like wet AMD. That's treatable, but it has to be recognized to be treated appropriately and quickly, right? So it's not necessarily that I think anything bad's going to happen to anybody. I think for long-term care, and sometimes, maybe 15 years in, you wonder, well, should I have gotten this picture 5 years ago, 10 years ago, right? Sometimes it's helpful in just tracking progression. I don't know. Not a very succinct answer, Jess. But.
No, that's a great answer. I appreciate it. So, let's say you're in Wyoming or Arizona or one of the Dakotas.
Yeah.
Would you advocate those people go someplace that? How do we know a retinal specialist is good enough?
So I hope any retina specialist is good enough, but I also understand the question. So for example, Foundation Fighting Blindness has a directory of people who have sort of self-identified as being, self-identified as being retinal genetics experts. There's a group called the American Society of Retina Specialists that has a geographic directory. You have to pass some criteria to be a part of that organization. But I also, I did a year of training in Iowa. I'm from the Midwest. I also think general ophthalmologists and general optometrists in those parts of the country, they are amazing sometimes, right? They know so much because they have to be able to take care of everything. So sometimes it's very location specific, which means I realize I'm not being very specific in the feedback I give you, but.
No, that's wonderful. And someone needs to help me because I'm naive, and pardon my naivety, but on our website, do we have resources for parents to get that information that you've just referred to? And that's my first naive question. And my second naive question is, should we?
Yeah, I'm sorry. Talk about it because 2 years ago I was passionate about that, like thinking of making a map of all the researchers, but it's a lot of work. And I'm wondering if AI could help, but like just to even have one specialist per region, you know.
I wonder if you
Yeah.
could just piggyback on what's been done already and just
Oh, yeah.
link out to like the directories that are already there, right?
Cool.
I think so. You can ask. Yeah. The other piece of it is I'm always just really conscious of people's resources, and that is time, that is financial, and so if somebody is getting good care locally, no matter what the label of that healthcare provider is, I don't want to make them travel just to travel. So.
I was just going to say, I'm curious how many in this room have had this experience where you can't get to that very qualified retina specialist, but you go to someone you think they're fairly good, and then you're waiting, and they're back in the back room looking it up. You know, they don't know what it is. They can't even speak to it, and it is the most disheartening thing. We have been to many appointments like that where we couldn't get down to Emory because it was, a 4-month wait, and my son was having a lot of problems at work, and they had to go down onto Google and look it up.
Any more questions? Alrighty, well, thank you very much, Dr. Huckfeldt. Great presentation.